Okay, so let's just jump right in. We had questions out to students and also on social media. And basically we were asking is what do you want to know about starting your field work? And then like what do they wish they knew before starting their field work? So two different groups of students. And we're going to be discussing all these. So let's just jump in and start let's just talk about fieldwork and OT and just basically what's the difference between a level 1 and a level 2 fieldwork experience.
So your level 1 is, I think there's a little misconception is that you may or may not be with an occupational therapist on your level 1. And I think so a lot of times there's different programs, may have more of a traditional level 1 where you are in maybe a traditional OT setting as well. You might be in a hospital or nursing home or in a school-based setting working with an OT. I actually had a level 1 where I was with an OT. But then you also may have a level 1, which we call more non-traditional sites, where you could be in a after-school program. You could be at a mental health facility or center. I have had, or our students at the program where I teach have gone into senior wellness centers and participated in a level 1. So the level 1 really is kind of learning more about the population and working with the people than it is more or less learning how to be an OT. I really think I tell the students to try to just absorb learning about the population as much as they can. Trying to learn about, if you've never been around children
Yeah.
and going to the school setting, or I have the opposite. I have a lot of students who are very apprehensive about being around older adults. Maybe only older adults they've ever been around, or maybe their family members or grandparents, and they're nervous. And then they end up going on these level 1s and having a wonderful, great experience, and maybe even thinking, oh, well, maybe I would want to pursue working with adults as an OT. So that's how I always try to, deliver it, but present it to the students. Because sometimes there is a little bit of disappointment if they don't get that traditional 1 week.
Yeah. Yeah. And it's 1 week. And they're
different programs have different ways of working it through the curriculum. Okay. So our program, they do 1 week in pediatrics. They do a 1 week level 1 in an adult geriatric setting, 1 week in a rehabilitative setting, and then 1 week in a mental health setting. Okay. And then there are other programs that spread out the level 1s throughout the semester. So instead of going all week for 40 hours, they go maybe for 3 hours every Friday, but they go the whole semester.
Right.
So there's different ways of doing it. And even when I was a student, one of my level 1s was that every Friday I went to an assisted living. And then the question is well, who's supervising me if the OT isn't there? Right, right. So there is a point of contact, and the point of contact could be a social worker. It could be a rehab director. It could be another discipline. It could be a PT or an SLP or an OTA. So there are a lot of different people that can kind of be, in charge.
Right.
And those would be the people that fill out your course of eval, not your course of eval, but your field work assessment at the end of that week. So at the end of that week, there is someone that is responsible for kind of, you do have a point of contact. It's not like you're sent out into the abyss. Right. Hopefully not. I mean, I'm assuming, hopefully not, that you have someone that, you check in with, that is, you're just not sent to a place without any supervision or anyone watching you. So that is the biggest difference, I think. Misconceptions between what a level 1 is versus what everybody knows what a level 2 is. They kind of know what they're not expected to do, but they know what a level 2 looks like. But then again, it's managing that expectation I try to do for students in the first semester of please have an open mind when you're picking or when you're selecting your level 1s, because it might not be what you observed when you were doing your volunteer hours.
Right, so. Right. And level 2s are 12 weeks at one facility. And how many level 2s are people doing?
It depends on if you have a master's program or an entry-level doctorate program. So for the master's program that I currently teach in, they do two 12-week field works. And then in most entry-level doctorate programs, you have your field works, and then you also have your capstone. So they have their fieldwork experiences. And there are some other programs that do things a little bit differently, and they may have 8-week field works. The school that I graduated from, we did 3 8-week field works instead of 2 12-week field works. That's very they've since migrated to the 12-week format, but that is kind of more of a very atypical model. So the 12-week is pretty typical. And like you said, they're going to be in that one setting. So if that one setting is ortho outpatient, or that setting is working in a skilled nursing facility, or they're working with a school system therapist. So wherever they pick, and they have to be with an OTR, they have to be with an OTR, and an OTR that has been out of school for at least a year of practice. So they have to have, at least 1 year of practice before they can take a level 2 student.
Yeah, that's intimidating a little bit. Like I remember I had a student, I think I was almost 2 years out, and I was excited. I was like, I'm gonna do this, but it was scary, but I learned a lot, let alone, and as well as the student. Okay, so I'm gonna ask a couple questions about like preparing for field work. So we're gonna kind of start there, and then we'll kind of dig into like the nitty gritty.
The more fun stuff.
Yeah. It's like, gotta set the stage, and then we're gonna. Okay, so one of the things is like, how do I best prepare myself for heading into field work? That's one of the questions, and that's a big question. We can just like kind of give an overview, but like how, another question that someone had was about like, tools or resources or interventions or, approaches. Like, people want to feel prepared. And how do you prepare yourself for a field work?
Well, I think I always tell students, to do your research about the fieldwork sites that you're before you prepare. Make sure you know what you're getting yourself into. And
Yeah.
Sometimes it's out of their control. We have a lottery system at our university where I teach, and so a lot of times, the fieldwork site, said they would take a student, but then something happens, they can't take a student. The contract fell through last minute, someone leaves or is out on, some type of maternity leave or something. So we have had to scramble. So our fieldwork educator, and I am not the fieldwork educator, but the fieldwork educator, then we're all trying to help out, reaching out to practitioners and people and say, will you be willing to take a student? And so it's not always the case that you may have like, I want to go to this place, and it works out that I get to go to the place. But if there's any control on the students end, if there's anything that students can do to really know what, they have an interest, for example, in neuro. And, I have students come to me a lot because I worked as a neurotherapist, and they say, I'm really interested in neuro. What do you think about this facility? So I think the best thing I encourage students to do is like to do their own kind of fact check. Ask their fieldwork coordinator, do you think this is the best fit for me? Ask their advisor or their own professors. If their academic fieldwork coordinator doesn't teach them directly, or maybe they don't, the academic fieldwork coordinator sometimes might be hybrid, or they might not have as much face-to-face. They may not know that setting may not be the most appropriate fit for the student at their level, at the time where they are in their education. So I always encourage students, reach out to your professors, maybe even have that hard conversation of, do you think that this setting is the best fit for me for my first level 2? And then that, the people that know them best can kind of help guide them of saying, that acute care neuro might be a better second level 2. And you might want to start with, if this particular student, maybe you want to start with skilled nursing for your first level 2. So sometimes I feel like before we start to prepare, I want to make sure that they're selecting the best fit. It's always like that best practice and best fit for the student, because I have seen it happen when I've told students, I really think that you should reconsider And then later they come back and say, oh, now I understand.
Yeah.
You know, now I understand why you said this might have been a better second level two,
Mm-hmm.
but maybe not my first level two. So I feel like before they even prepare, making sure the selection process is really like helpful to them. And I do think that fieldwork educators start having those conversations with students, like, beginning of school, beginning of their didactic courses. They start having those conversations of picking sites they're interested in and making sure that they really are placing the students in an appropriate place. But the student has to do some self-reflection as well.
Mm-hmm.
Even though it is a place that looks great, is it really a place that they see themselves thriving?
Right.
So, like, we have an example that I have is like some of the places the students go might not be 5 days a week. They might be 4 10-hour shifts. And saying to the student, like, is that something that you think that you want to do? And I think it sounds glamorous, like, oh, I have a 3-day weekend.
Yeah.
But then they get into it and they think, wow, 10 days is a lot. And I'm preparing for the next day and doing treatment plans for the next day and maybe finishing documentation. And so I think a lot of it to me is like just trying to encourage the students to have that hard look at maybe what's a better fit. And then also not picking locations based on locale, like maybe sometimes you have to for financial reasons, but I always encourage students to, pick the better play. I said better place. Pick the place that might help you in your trajectory versus the place that's just down the street because it's convenient. And then once they get to the place, I always encourage them to reach out, which that's a pretty basic step that they have to do anyway, reaching out to their educator. And I've been a fieldwork educator, so I know asking the educator, walk me through a typical day at your clinic or your hospital or school. What's your caseload like? What frequent diagnoses are you seeing? What standardized assessments are you using? What's your productivity requirements? What are and I think after you get all those basic questions, like where do I park and what do I wear and down, but I think asking those questions, if not before you go, even the first day, and that can really help you prepare so you're not walking into this abyss of like, I'm going to this hospital, but I have no idea the patients they see. And then the students can really kind of take that self-initiative to go back and refresh on those assessments or those tools, or look for outside resources, like resources you provide, or and really kind of feel like what will help them. And that, like, I should say that cliche toolbox that they have, what is going to help them, but they really don't know until they have that discussion with their clinical educator. Because I do think that even the schools, I am unfamiliar with a lot of things. The students will ask me, I'm going to this setting. Do you know about the hospital? No, I don't. I know it's an acute care hospital, and you need to ask your educator, like, what, are you on one unit? Are you on, or do you float all over? So those are the questions they really need to kind of go straight to their educator to get. And then once the educator provides it with them, then it's up to them to kind of lead the charge.
No, I think you just hit the nail on the head. It's just like there's so many things, but I think just being prepared and really understanding what your setting is helps so much, because they may do assessments also that maybe you didn't learn in school, or maybe you can bring some assessments and different things that you've learned to that population that they don't do, because we tend to get a little stuck in our ruts of like what we do. And we learn as when you're in a facility, if you're a CI, or maybe you're not even CI, you just work with other students that are there. Like, we learn a lot from students too, because they are like most up to date on maybe research or some of those things. So don't ever underestimate your role on how much you contribute, not only to your patients but the team, because you really do.
And students bring so much back. I am always learning about new assessments. That we, might not be part of their our curriculum
Yeah.
or might not be things that we're teaching, but then a student will come back and say, oh, is that I learned about this assessment, and I'm like, oh, please tell me about it,
Mm-hmm.
because that sounds wonderful. Let's look at the validity of it, and let's understand kind of why they're using it, and
Mm-hmm.
if it's something that I maybe want to introduce in the classroom. So I mean, the students are wonderful at that, and then they're also wonderful at telling us, like, hey, I wish these are things that I didn't learn that I should have learned,
Yeah. 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 Oh my gosh. Yeah.
Yeah.
And those are some of the questions also.
Yeah.
We'll get to those.
Of like, this is what
Yeah.
I feel like I need more of. And that's great for any program. I mean, as far as like improvement, quality improvement,
Mm-hmm.
all programs need to know where their gaps are. How can they, improve? Because really, at the end of the day, the students are going to be clinicians in less than 3 years. We have to fit in as much as we can in the time that they're in the classroom.
Mm-hmm.
So.
Definitely. Okay, how do you start off on the right foot with your CI? Or the question is proactively communicate with my supervisor to ensure, the question is to ensure I'm on track and getting the most out of my field work, right? Because we hear all about the experiences of like, quote, good CIs and challenging CIs and ones that are hard to communicate, and what's your role as a student and what's their role as an educator. And sometimes those don't always mesh. But what would be a good way to start off on the right foot with your CI?
I feel like just it's like any communication style, learning kind of what the best way of communicating it. So I know that when I was a CI, I didn't necessarily want students asking questions in the middle of a session, but
Exactly.
I was fine with asking questions maybe in between patients.
Mm-hmm.
Whereas like some people may say, let's debrief at the end of the day, and not really. So I feel like having kind of an expectation of like how they communicate, well, and making sure that your body language is also communicative. If you are someone that, maybe always has your arms crossed and never smiles, and, and just maybe it sometimes could be off-putting, maybe not just to the CI, but to the patients. Mm-hmm. And so we have had to even have conversations with the students about, just trying to have more, just working on their body language, not just their verbal language, and so those are just some things that like we have talked about. And then that all leads into professionalism too, of maybe not excessive phone use or showing up late, and
things
that can also hurt your relationship with your CI.
Yes.
So you want to be communicative, so if you're running late and you're stuck in traffic, like let someone know. Or if you have, a family member that's sick and you think that you have to be out, or that you're not feeling well and you need to be out, and so instead of like avoiding, those tough conversations, like maybe letting them know. And so I think that is, again, part of the professionalism discussion, but just making sure that, you start off on the right foot, but that I'm more concerned that they keep the footing. Like, that they start out.
Yeah.
I had a CI, my first level 2, I went to San Diego, and I'm on the East Coast. So I flew all the way across the country, and a friend of mine, the place that I went provided housing. So that was the incentive for me to go.
Yeah.
Of course, I wanted to go to California and have free housing.
Totally.
I lived in San Diego by the beach. And so I had a friend who let me borrow her car.
Oh.
I mean, so I had like the best, scenario. Mm-hmm. I show up at my fieldwork site the first day.
Yeah.
And there's a PT is there, a PTA, and they said, oh, Julie, she'll be here soon. She normally comes in around 7:15. They told me to be there at 7 a.m. And so she comes in at 7:15. I introduced myself to her, and she said, hold on, I'll be right back. And we walked outside, took a phone call, and came back, and she said, I'm so sorry. I did not know you were coming. Oh. And I was going to quit today.
No.
So she was like, I'm not going to do that to you. And because she was a contract. So she was in contract. And, but she was going to leave her contract, mid-contract. She was leaving. She was unhappy. And so she said, but I'm not going to do that to you. And, you know, of course I'm thinking, I mean, I'm just deer in the headlights. Like, what? I've just got to California. You don't even know I'm coming. Now I don't even know if I'm going to be able to stay.
And she's stopping mid-contract. You're like, oh my God, like, what's so bad about this? Like,
it was a chaotic facility. And so she said, we're going to make this work. And I so appreciate her flexibility, because I mean, had she not, I don't know where I would have ended up. They would have found a place for me, but it would have delayed everything.
Yeah.
And so we went to she was, I think, kind of in between 3 different skilled nursing facilities. So because it kind of was nice, but because she had a student, they tried to keep her more at one than the other. So that was a little helpful, you know, but I think she did leave shortly after I finished at my level 2, but just knowing that, yeah, I mean, you don't, sometimes you show up, and I hate, of course, sometimes they know you're coming, sometimes they don't, you know, because I had reached out before and did all of the fact check, but since she was a contract therapist, I'm doing it with, you know, the I guess the facility that hired her, you know, so I had a different person. I didn't talk directly to her, you know, so it's more of the like rehab management team, you know, the DOR, whoever I had spoken with, who told me, you know, where to park and what to wear and what time to be there, and all the questions that you have as a student. But yeah, she didn't know I was coming. So I always tell students, I survived.
Yeah.
You know, I mean,
you made it.
I made it.
Oh my gosh. I know, like, you're just talking a little bit about CIs. I think one of the things that you learn so much in your level 2s is just like how important soft skills are. Like soft skills, being able to listen and build rapport, and, you know, your therapeutic use of self. And you're not just using that with your patients. You're using it with your CI. You're using it with your coworkers and everybody else on the team. And I think sometimes those are underestimated because we focus so much on like the clinical aspect, which of course we need to know, right? We need to know, but like showing some of those softer skills, like, and kind of growing those is so helpful, because even if you don't know the answers, and you can honestly say, you know what, I don't know the answer to that, or I will get back to you, or I need to do some research on that. Like, being able to say that, that's all people want. I mean, I'm talking about patients, I'm talking about your CI, like no one expects you to know everything. And so like kind of like humbling yourself to know that this is part of the process is so important.
Yeah. I mean, a lot of the questions my students ask me, they know I say, you know, I don't want to tell you the wrong answer, and I'm not going to, you know, I will find the answer for you.
Yeah.
You know, if you can just be patient with me, you know, to be patient with me and give me time to find the answer, I will find the answer for you.
Yeah. Yeah. And I think students are a little intimidated by saying things like that, right? Because a lot of people have this, you know, imposter syndrome anyway about just being there. But yeah, I mean, we're still looking things up, right? We've been therapists for a while, so.
I'm like constantly.
Okay, one of the other questions is, how are students evaluated in fieldwork?
So they actually have a midterm that they are evaluated at that 6-week mark, and then they have their final fieldwork assessment that is completed at the 12 weeks. Now, I should say, like, different programs and or different facilities, they may have a different, more micro assessment. You know, they might have you fill out a weekly goals summary or a weekly assessment on your performance, or things like that. But just in your true, as far as like across the board, you know, you have your halfway and then your final. And, you know, your scores, there's a little rubric that kind of tells you it's a standardized form. So it's not a form that's different for every school. You know, everyone kind of has the same standardized form that they use. And even though, again, I have not been the fieldwork I keep saying fieldwork educator. Fieldwork educator is at the school. Clinical instructor is on the fieldwork side. You know, so it's like confusing language. But the fieldwork educator normally goes over that form with them, you know, in the program. You know, so saying, this is what, you have it kind of up front, just like rubrics in school. When we were in school, I didn't have a rubric.
No,
Like, it was
no,
basically like,
no.
do this assignment.
Just-
Now everything has a rubric, which is important because it really holds the professor accountable when we're doing our grading. And then if the students ever come back and say, I disagree with this, and I'm like, okay, well, let's look at it. But I really think that this is kind of the same, as the sense that it's a standardized form, and the fieldwork educator at the school should be, going over it, so they kind of have a clear expectation of like what they're going to be assessed on. And then just looking at that grading box of what is a kind of, I shouldn't say normal, but like there's a passing score at midterm, and then you have a passing score at final, but there's almost like, what is to be expected at midterm? And I think sometimes, because it's a grading from a 1 to a 4.
Okay.
And I think sometimes students at midterm, if they're not making 3s and 4s, they're like, it rocks their world.
Yeah,
And so
yeah.
I would then like to have these conversations with students of saying, this is kind of where you're emerging. These are the emerging areas. Like, if you were, so I do feel like the clinicians that get it, like the ones that are grading people really truly based on that, and are giving people 2s and 3s at midterms and more 3s and 4s at final, are really kind of adhering more to kind of how they should be grading.
Yeah.
And then there might be a CI, they don't want to give a student a bad grade, so
Right.
At midterm they give the student all 4s or something, and then the
Right.
student's like, oh my God,
I'm amazing.
yeah. Like, well, what else? What do you have to work on?
Yeah, it's like, you're a student. We have things.
So I think just like looking at it before you actually are graded on it, and then the student does their own assessment of a site. They do kind of a assessment of their fieldwork site, and then that's always important for students going forward, so they can go back and see. And that's, again, that preparation of going in and seeing, what's the typical diagnoses that they're seeing, what's the typical caseload, and that can probably change year to year too, and it might even change month to month with like census and
Right.
Or you went to that same hospital, but you were on this floor in the hospital, and when I went to the hospital, I was not on that unit at all. So that was what I did when I was a student. Is we had a file cabinet, and we went into the file cabinet and like pulled out the folder of the hospital, and you would look in the file cabinet and it would have all the evaluations that previous students had filled out.
We had a thing where like we would write a letter. I mean, like we would write a letter to the net following,
Oh, that's nice.
Yeah, it was really nice. I like that.
I mean, everything is electronic now, but still something like that would be beneficial. And then that's there you go. Students reaching out to, if they know someone that has been at that site previously. I think a lot of times you're recycling these contracts and these fieldwork sites.
Yeah.
So like where I teach, we have students that are going on fieldwork in the summer of 25 that students in the fall of 24 just left from. So I'm able to say, well, maybe if you can connect with this this alumni or student, they can give you a more recent kind of day-to-day
and realistic, kind of like the nitty-gritty,
So, I mean, there's nothing wrong with doing your investigative work, like,
agreed.
Making sure you know where you're going, the good and the bad.
Yeah, for sure. At your university, do you guys have do you have to do like a peds and a physical disability, or like back in the day we had to do I went to the University of North Dakota School of Health and Sciences, but we had to do like a mental health. We were a very big mental health, right, at the time, back in the day. So we had to do a mental health and a phys dis, and then you could do an optional pediatrics is how they used to do it, right? So is it standard? Is there like a standard now, or is it depend on the school?
Well, we don't. Same for me. Where I went to the Medical University of South Carolina, and we did not have to. You can't do it in the same setting. So I mean, you can't do outpatient ortho, and then I'm going to go to outpatient neuro.
Right. Exactly. Yeah.
So there's got to be a variety of settings. They were not strict with us on populations. So you couldn't do 2 pediatric settings, but pediatrics wasn't a requirement. So
Okay, that's it.
I
Yeah.
did 3 adult settings. I did skilled nursing, inpatient rehab, and acute care.
Oh, okay.
I was able to do 3 adult settings, and then the university and I can only really speak on the ones that I've been to and the ones
Right.
that I teach at,
Mm-hmm.
and the one that I teach at, they do not have to do a pediatric placement,
Mm-hmm.
but so that's not mandatory. But if they do they can't do 2 pediatric placements. So if they do 1 pediatric placement in a school setting, their second placement has to be adults, so it has to be, and the same for the adults. We allow them to do 2 adult placements, but they just have to be in 2 different settings. So if they do inpatient rehab, then they could do outpatient or skilled nursing.
I see.
And that's just, again, like the 2 that I teach for and where I graduated from. But I'm not sure, every school has their own way of doing it. I do think that I have a little bit of a different thought process than some of my own colleagues. Like, some of my colleagues really push students to do peds, even if it isn't required, because they think like, oh, it'll really help you for your MBCOT.
I see.
And so they think, you're not going to get this will really help sharpen your lens for your MBCOT. And I understand that. I think I'm biased because I knew that I didn't want to work in pediatrics.
Yeah.
And then I went to a university in UIC where I didn't have to do a pediatric rotation.
Mm-hmm.
So I did, like I told you, skilled nursing, inpatient rehab, and acute care. I ended up getting my first job in acute care. So my progression really helped me get my, help get the first job. And I ended up, I didn't feel like it hindered me. My education prepared me for the pediatric, ACOT accreditation standards that we needed to pass the MBCOT. Mm-hmm. So my classroom, setting did. So, I didn't spend extra time studying for it.
Right.
The chapters that I had to go back in my preparation course that I took, that I had to really focus on because I didn't do peds. But I think there's 2 schools of thought. There's certain people who are like, you really need to do a peds because you need it for your MBCOT. And then I think that I just hear our fieldwork educator that I had, he was my mentor, and I just thought the world of him. And he was the one that was basically like, you're never going to do peds if you don't have to, why would you do peds? And I think I just always have his voice in my head, and it worked for me. And so it's hard.
I know.
It's like, I think you need to do this.
I know. But it's, I don't know. I don't really have an opinion. We had like I said, we had to do a mental health, and that was a crazy experience. Because I was in a forensic behavioral unit, so criminal background. So that's a whole. I could tell stories all day about it. But the number of people that I've heard are students that just mostly through social media and being like, I ended up doing a sniff level 2, and they're like, I never thought I'd work in geriatrics. Obviously, because I love geriatrics, so I am always like, people have such biases sometimes against geriatrics, and obviously I have a passion for that population, and so I'm like, see, it is fun. It doesn't have to be this all doom and gloom. So I kind of see both sides. I never worked in peds in field work, and I never chose a field work because same thing. I'm like, I'm never gonna work in peds. Then I never have. You know what I mean? So I don't know. I think I probably would have felt different if where I was living there was no jobs and I would ended up working in a peds clinic. I'd be like, crap, I wish I would have. So I don't know. I can kind of see both ways. Okay. One of the other questions is, what does a typical day of fieldwork look like? I think people worry that they have to how hands-on involved are we? How does that progression look? What are the expectations? Do they think we know all these things the first day? And I think people kind of worry about that they are expected to kind of jump right in. How do you respond to that question?
it is like the true OT, like it depends.
I know.
It's not a cookie cutter because there is a progression. Okay. So if you like follow, maybe I don't even say like how it should be, because I had my first level 2 where they just threw me in. There wasn't like any getting in the shallow end. Like it was basically like I was doing evals week 1, and my patients. And then I have students that come back from field work and they're like, I'm carrying my own caseload by kind of like, I say like when you look at the standardization form of how they're graded, it's more like by, midterm, you're carrying this percentage of the caseload. And then by the final 12 weeks, you're carrying 100% of the caseload. And so if people are doing kind of like that slow transition, some people do that. They might say, that first week you're just observing and you're just shadowing. But then I didn't have that experience. I had the experience of that first week. It was basically like, do you need anything? Like,
here you go.
Yeah, there you go. And I think that you have to know that it is I think one of the things that students have to kind of switch their mindset to, that it is getting back into the workforce. It is a job, so you're not sitting in the classroom all day. You're getting up, you're getting up early for class anyway, but you're on your feet all day, no matter what setting you're in, really. Even outpatient, or, you're having to, maybe you're eating, you're not getting like a long lunch break. You're probably getting like a quick lunch break, and you're trying to find times to document throughout the day. And so I think a lot of it is just like trying to navigate this new schedule, because the demands of being in the workplace versus the demands of there's so many demands of being a student, but the demands of being in the workplace is just a different schedule. And so it's like the whole OT framework of the roles, habits, routines that you as a student, you have to kind of shift that into being, you're really you're cosplaying as an OTR for 12 weeks, So that's what students always come back and say, like, God, I didn't realize I was going to be so tired, or, and, it's, and I'm a big advocate for like that, work-life balance and student balance, because when I was a student, and not to say anything negative, but it just wasn't even discussed.
No,
it was
not at all.
Like, get up and, like grin through it. And, it just, there was no, kind of, I don't even know. There wasn't any, don't show any signs of weakness. It's kind of like, just do it. And I think that with my own students, with the students I teach, I'm always like, when you leave, your fieldwork site, we do these mental health playlists in our mental health class, like where they make a play, and I'm like, put on your playlist, go for a walk, do your gratitude journaling, do the things that we did in school, and we try to do thread those throughout the curriculum. And I'm like, we don't do them just to do them in school. We do them so you guys will do them when you're on field work. And really setting boundaries and making sure that you're not bringing your work home with you. And
it's so hard. It's so hard.
And I was terrible when I was a student. I did, I think that, and even my first job, I remember I worked at the hospital where I graduated from, and we had a stoplight, a red, green, I may have told you this before, it was red, yellow, and green. And so when you clocked out at the end of the day, the stoplight would tell you how productive you were.
No.
Like a big giant stoplight. Okay?
Yeah.
Okay. And so I remember, I was a new grad, and of course you want to be yellow or, and I just remember always being in the red, like always in the red, So I would, this is so bad, I would clock out.
Yeah.
And then I would go back to my computer, and I would sit there and finish my documentation, which is, don't do that.
Don't do that. But yeah.
I shouldn't have done that.
So you're not red? Is that so you weren't in the red?
I wasn't red.
Oh.
But I wasn't getting paid for that time.
Right.
But I shouldn't have been doing that. But I'm saying, I was so fearful of, being in the red every day,
Yeah.
That was the only job I've ever had that, though. Thank God.
That's pretty brutal, actually.
Pretty brutal. Yeah.
That is pretty brutal.
And so people think people in the South are nice. I'm like, that, I didn't understand. That was brutal. And And then, I think that it's just your typical day, like I said, is really just whenever you kind of fall into your routines, then you can manage your expectations of knowing, like, that Fridays are going to be a busy day. We're probably not going to get out before 5 o'clock, or, whatever it is. And really kind of taking the time to rest. I think a lot of times, students, they will, and I was probably guilty of that, but like burn the candle at both ends.
Totally.
They get off FIELDWORK and then they're going to go out of town for the weekend, and then they're going to fly back like Sunday midnight before. And I'm like, hey, if that works for you, that works for you. That wouldn't have worked for me. I had to kind of be very, I had to like compartmentalize everything when I was on FIELDWORK. I had to like kind of separate, I was like, this is all I'm doing.
Right.
This is my focus. And, a lot of people can't do that because you might have families and parents and children or other people that you're taking care of, that like when you leave FIELDWORK, you got to go take care of other people and jobs you might be working on while you're in FIELDWORK. We try to encourage students, to not work, but I know that that's not, not everyone has the luxury of not, and so we have a lot of students, that work night shift and weekends, even when they're on FIELDWORk.
Yeah. And,
so I'm always kind of checking in with them, making sure that they're taking care of themselves, so, cause it is a 40 hour a job, at least maybe 36, depending on where you are, but most, it's 40 hours a week that you are working, as an OT student.
Yeah.
So,
I actually also remember, like, when you're a student, you're sitting a lot, and I remember being like physically tired, like you're walking around, you're doing all these things. I remember just being like, and obviously like cognitively, emotionally tired, but like, I remember being just tired, like, big time.
And I had my third one, was in a hospital, and it was in a neuro ICU at Vanderbilt in Nashville. And my CI, we had lockers where we keep our things in. And she would make me go to my locker every morning and drink. She was like, I want to see you drink water.
That's a good idea.
And she had two children, so she had like, she had like a mama bear mentality, which I appreciated.
Mm-hmm.
She would be like, did you eat any breakfast today? And I'm like, I grabbed a protein bar on the way out. She would make, she's like, we're going to the cafeteria, you're going to get a banana. Because she had, this person had a ton of students, and she would tell me horror stories of students passing out all the time. Passing out and injuring themselves and putting patients at risk. So she was like, no, I'm not playing around. Like, you're going to drink, you're going to be hydrated, and you're going to eat. And so I was like, okay, like, start down a banana really quick. And I think that because that had, she had seen so many kind of like bad things happen.
Well, in passing out during a FIELDWORk, I did. so there was a couple things I wasn't prepared for. Yeah. Okay. So I can attest to that one. Okay. One other question is, how much time do we have beforehand to prepare for a client? Like, is there any way to know about clients in advance so we can kind of prepare for treatment, treatment planning or assessments and that kind of thing?
And, again, locale dependent, but, I always tell students, boundaries are important, and I don't want you to get to the FIELDWORk. I'm not telling you to go like 30 minutes before, but if you can at least get there, maybe earlier, if your shift starts at 7:30, you get there at 7:20 or whatever, and you have time to do a thorough chart review. So I'll just use, I always had great level 2 students that when I got to work, they were already there. This was when we were living in DC, so obviously you're navigating like traffic and parking and all these things, and I am like not the most punctual person, so I'm like rolling in at 7:30 on the dot with my coffee, and the students are like, we've been here waiting for you, and so I think just having that time to, if you know your schedule for the day. So,
right.
in a lot of settings, you will know your schedule for the day. You get to the facility and you're like, okay, these are the evals that we have. These are the treatments that we have. And, some facilities, like an inpatient rehab, for example, you have a set schedule, or an outpatient, you have a set schedule.
Exactly.
In the school system, you're seeing these kids this day, so you may be in a setting like acute care where you don't have a schedule.
No.
You're just given these assessments and given these, but you might still know who you're assigned. So I think, doing a chart review, we have these kind of small research groups. And so those students, I always give at the end of the year, I always give them a little notepad, that fits in kind of your side pocket of your scrub. I always say, take this to your fieldwork and, use it to take down notes, or write down diagnoses that you're unfamiliar with that you can go back later and look up, or a medication. I mean, or anything that you see that you're like, I have no idea what this is, or
right.
I want a question you want to ask, or because I do think when you're doing your chart review, then you can go and ask, when your CI gets there, I've never heard of this diagnosis, or I'm not really familiar what the contraindications are, and making sure that they know that you're asking, they're not going to fault you for not knowing, they don't want you, hopefully they don't want you to be overconfident and pretend that you know something that you don't know. So I think that really is more, it's very much self-initiated by the student, and if you're working in a place that you're seeing the same patients, maybe you have a caseload, and these are the patients you're going to see until they discharge. That helps,
right?
I mean, then you can prepare for the next day. I want to do this in my treatment session. I want to get, I know we have this, and we have this at the facility. We can incorporate this in the treatment session,
right.
Or something you want to bring from home, or my colleague, he is great. He has this thing where he calls it ball, which is, it's not, I mean, everybody uses the term, but he always says balling on a budget.
Yeah.
He says like, we go to the dollar store and I want to get I really need cotton balls, or I need a pack of cards, or like something that you think might, you're not expected to spend the money, but if it's something that you're like, well, I'm going to be there, I'm going to get this anyway. I always feel like that helps with preparation if you know your caseload. If you don't know your caseload, then you have to just kind of come up on the fly sometimes with your activities, which is hard. I think like being able to go and do that thorough chart review, looking at the goals that were written. If you were the OT student, but you weren't a part of the evaluation, go back and look at the goals. Now, if the patient has been there for 8 weeks, look at the more recent, don't look at the eval, maybe look at the recent progress notes.
Yeah.
I was telling students that the other day, because I was saying, working PRN, you really want to make sure you're working on things as a PRN therapist that are important to the patient. You're not just, willy-nilly just saying, let's just do this. And so really going in and looking at, not just the chart review and prior history and all those things, but looking, and maybe sometimes looking at what they did in other therapies, what are they doing in PT? Asking those questions too, when you're doing your team rounds in certain settings, we have rounding, and maybe you're kind of finding out what they're, listening on what they're doing with other disciplines, because that helps shape what you're doing, in case there is some crossover, of what you're doing. You're like, oh, you're going to be working on that today in therapy. Okay, then I definitely don't want to do that with them, because that's too redundant. They're not going to do that twice. So communication is important, not just with your CI, but with the whole team, with everybody in the team.
The whole team. Exactly.
If it's, education model, the teacher, the other therapist, like whoever, if it's, just communication with the team, so, because I always say, like, even though your CI is going to be the person, obviously, that you report to, the person that's grading you, but you're being watched and observed by a lot of other people.
Absolutely. Well, and you learn other things from other people too, right? Like, I mean, you learn so much from other disciplines and other therapists, because we all do things a little bit differently. So it's so true. Okay, now we're going to transition to the question that we asked some of the students that just got back from fieldwork was what they wish they knew before going into the fieldwork. And it's really interesting because when we asked students that are preparing for fieldwork, it's there's so much unknown, right? They're like, oh, this and these things I wish I would have known. And then when we say, what do you wish you knew before? It's, completely different. So some of the things that they said were, it's more along a set of questions and more along, we can just kind of say, definitely intervention ideas,
Yeah.
right? And then one of the things was like working on ADLs a lot without doing the same thing over and over. And that's actually one of my big, not soapbox isn't the right word, but that's one of my things that I really love, like that I, help teach in like the OT Accelerator and different things like that is like, once you get that experience under your belt, and you'll even see it somewhat on field work, you're like, okay, toileting, you can't just do the same thing over and over and over and over. And it's really using those activity analysis skills. I swear to God, like you have to really, and say like, what is the problem? And then figuring out what that body function is or whatever that may be, and how can we do something meaningful from that? If it's balance, how can we work on balance? But we're still working on the goal of toileting. So, it's just like those kinds of things. I think people really kind of fixate on the activity sometimes, which is important. But really it's the critical thinking skill and the activity analysis so you can determine what you need to do. So that was kind of interesting. But it was always like more intervention ideas, right? Which I think is really common.
I taught in an OTA program before I taught in an OT program. OTAs, that was their strong. They were, my personal experience was that's their strong suit. They're the experts when it comes to intervention. And so they were so creative, and then it felt like that was kind of interesting for me because then I went to teach in OT school, and then it's like again, like it's almost like I don't know what to do. Even though, like I'll give you an example. We had an assignment that they did a group. They had a case study the other day, and they had to come up with interventions. So they had to come up with interventions. They're ADLs, therapeutic exercise, therapeutic activity. They come up with interventions. And then fast forward, they have a lab practical where we're asking more questions like on the spot. We're giving, and so I give a very similar, because I'm like, I'm not trying to throw any curveballs here.
Yeah.
Very similar diagnosis. And I'm like, you're the OT. Here's what they can do, what they can't do. Okay, give me therapeutic exercise. What are you going to do? Therapeutic activity. What are you going to do? And a lot of them were writing, and I didn't say give me an ADL, because this is more of an outpatient class. This is more of like an outpatient class that I'm teaching right now. And they all wrote down ADLs. And I'm like, well, ADLs are great. Of course I want you to do ADLs. You're OTs.
Those are our goals, right?
Yeah. But I'm like, but I specifically want you to like, not macro. I want you to look at like micro. How are they going to get to that? And I feel like I've been very fortunate. I have been very fortunate to work in settings where we work the patients hard.
Me too.
It's like we are dynamic, where we are not OTs that are, I'm like sitting and doing some passive activity. We are OTs that are having our patients stand to do dynamic activities and pushing them to the point of not pain, but maybe discomfort sometimes.
Challenge.
Yes. And I'm like, my goal is to fatigue you, not that you're so fatigued that you can't work with the PT, after me, but my goal is to work you hard. That's why you're here. And so I think like getting the students to understand, like you do in your courses and stuff, like trying to brainstorm like what therapeutic activities they can do, and what therapeutic exercises they can do. And I don't use an arm anymore. I don't use an arm bike. Okay. Like that's like something that I did in the first few years of practice, kind of out of feeling like desperation of like, I didn't know what, I don't know what to do. But then it was probably like 4 years into practice. So I've been an OT for 16 years. So it was probably like 4 years into practice. I remember it was like Glenn Gillen had a OTs choose wisely like thing where he was like, get rid of the cones.
Cones,
the arm, like all the things, and like we took those out of the hospital. I mean, I worked at a rehab hospital in DC. We literally took those things out of the hospital. We were like, get them out of here, because then you're not tempted to use them, So I'm not like an arm bite, but I do feel like if somebody can rationalize why they can use it, and
absolutely,
the patient, that's the other thing. If the patient is saying, this is what I want to do, then sometimes I'm like, okay, this is what you want to do. Then, it's not really meeting the need and the demand, but I do think that students have to be creative in the exercises they're coming up with. They have to be creative in the activities, and they need help. And we try to build that foundation in school, but I feel like they really learn it when they go to field work.
Totally. Yep.
They have to seek outside resources or they have to seek like your resources or other resources that can supplement maybe that disconnect. Because there is that disconnect, and I always say from the classroom to the clinic, there's a bridge that we try to build, and then their clinical reasoning skills are really formative on field work.
Yeah.
So we lay the foundation in the classroom, and we try to give it a lot of experiential learning. I mean, we have patients come into the classroom. I mean, every school does this. Every school tries to build some, they have, simulation labs, or they have, real people come in. I mean, everybody tries to give as much practice as possible, but nothing is in substitute of the real thing.
Yeah.
And, so I try to get the students out of the classroom as much as possible, but I'm like, nothing will ever be like when you are the student and you're on field work and you have these 8 patients that you have to see that day, and you are really just kind of like thrown in and immersed in the experience. Nothing will ever substitute that.
No.
So, I think like just trying to improve, like they're saying, like, I don't know what to do. And I mean, even when I was a new grad, there was an OTA that worked. I worked in acute care. That was my first job. And then I worked PRN in a nursing home. And I remember there was this one OTA in the nursing home. And I would always be like working with my client. And then I could like see her out of the corner of my eye. And she was always doing these like really fun, awesome activities. And I was always, like you said, like watching her. And then I would be like, I learned so much from like you said, watching other people. And then you're like, okay, I'm going to remember that,
Yeah.
And then, because I mean, of course you're going to do courses and you're continuing ed and all that. But like, don't be so overconfident that you don't think that you can learn from other people, So it's like, I'm all for like, mirroring them, modeling after them.
Yeah.
So that's what I always tell students, like, what are the other, and if they're like, well, they're not doing anything with them either.
I know. I mean, and there's so much to learn from other clinicians. And also sometimes, like, if you just are overwhelmed, I'm always like, keep it simple. Like, you have somebody that's in a hospital bed and it's like pulling teeth to get out. Okay, let's just work on bed mobility. Let's work on rolling. You know what I mean? Like, we can do some education. I think we feel like sometimes we have to have these huge, interventions, or we have to have these huge things. And sometimes that's appropriate and fun and exactly what we're going to be doing. But depending on the setting and everything, like, you don't have to. Like, you can do so much in a patient's room and be very therapeutic and help them achieve them goals and have them work hard. It doesn't have to be this big gym session every time. So I think those are things to keep in mind. I mean, I was known as I was like a room therapist. I felt it was like when I did PRN at, one of the nursing homes, I was like, I'm more efficient if I just do lots of things in the room. And they'd be like, you never come down to the gym. I'm like, yeah, my patients are doing great. You know what I mean? Like, I'm just like, you have to also do you. And that's hard at the very, very beginning.
Yeah. I mean, you're like, if I got 30 minutes, I've got 30 minutes and, and we can do this same activity, but we can do it in the hallway or in the room or whatever, So, and you have all like talking about being room therapists, sometimes you don't have the choice.
No.
Because of, precautions. I mean, there was a norovirus outbreak at one of the nursing homes I worked at one year. And I remember we had to do in-room therapy. I want to say it was like 3 months that we didn't come out of the room, and you would come out of the room and everything that you took in couldn't come out, sanitize everything. And so, I mean, not ideal, but you still, you're trying to make the best of the situation for the patient and for yourself.
I actually have a ginormous list of in-room treatment ideas. If anybody wants it, I'll put it in the show notes too, because like with COVID or precautions, or like some people just don't feel good, or like some people don't like being in the gym. Like there's a lot of reasons why they want to be in there or need to be in there, and so I have a whole list, and I'll add that in the show notes. So don't let me I'm like writing it down so I don't forget. Okay, let me go over a couple more of these couple things real quick. Oh, time goes by so fast. Let's see. Interventions. Make sure I realize that I am learning and I don't know everything. I thought that was really good insight, right?
Yeah, that's great.
Yeah, that's a really great one. That other disciplines are your friends and allies. I mean, like, depending on your setting, I mean, housekeeping. Housekeeping is huge. Maintenance people help you with like wheelchairs. I mean, like, really using the CNAs, huge. You want those relationships with them, and it makes your job and their job so much easier. And so it's not, I always find, if like you don't look at as an OT as this hierarchy, as in like our goal is helping the patient, and so everybody has their little part of the pie, and so how can we work together to make make it work for them. So I thought that was a good insight. Listen and have good rapport with coworkers and patients. Listening is huge. And then the other one is I didn't realize that sometimes working with patients that refuse or are not interested in being an OT. That's a whole skill in itself.
Yeah, right.
And I have a resource for that, and I'll put in the show notes so people can grab, because I have all sorts of, and that part of that comes with, like we were talking about before, with like, therapeutic use of self and kind of like body language and some of those more soft skills that you do acquire and learn as you go. And I think sometimes it's easier for some people than others.
Yeah.
But
I know for sure. And I'm really big on consent. Like I always tell the students,
100%.
We really have to if someone tells you no,
Yep.
like get out of here, I don't want to see you come back again, then I say, well, can I check on you? Can I check on you in an hour? It's, I might throw in a little or I might, I'll leave and come back or something.
Mm-hmm.
But, yes, you're going to get refusals, and how do you be creative, and why are they refusing? Like,
yes,
and it's it's not because they're non-compliant. It's because they slept like crap last night and they're in pain and they're unhappy because, their significant other is not coming to see them. And, there's so many things that students sometimes are just like in that narrow focus of like, we need to get this done. It's like a checklist. It's like something I need to check off my list. And I'm like, guys, we need to be a little bit more empathetic and understanding that, and hopefully you have a CI that can coach them through it, and hopefully you have a CI that's empathetic, and
yes,
that might be the case, so,
I always use the line of, they're not giving you a hard time, they're having a hard time.
Oh, I like that.
I like that because I use that with my kids as well. But it's just like understanding that they have a lot going on. Our CIs have a lot going on. Everybody has a lot going on. And so understanding that not everybody's going to have a great day, or like you said, understanding and having that empathy. So those were the major questions. I thought those were good.
They had good questions. I mean, I feel like it's so it's a nerve-wracking experience, especially going on field work your first time. I feel like by the time people do it their first time, they're like, I got this. I know what to expect. Or I have students that have a really great experience their first time.
Yeah.
Then their second is disappointing for maybe they have conflict with their CI, or maybe the setting is, maybe not a great fit. And, so there's things that, sometimes it's like that the tone was set, the bar was set really high, and then the opposite, some that had their maybe a negative experience. And so then they're able to reframe and go into the second one with like, all right, I know how I'm going to handle this if it doesn't go my way.
Right. Right.
So yeah, I mean, I think overall, like I always tell students, they always ask me about negative, like they want to know, like, do you hear about negative experiences, or do you hear about, and I'm like, I feel like it's like any job or any, I mean, I'm like, it can be very unpredictable. And I was like, but, you have to have confidence that, your school hopefully won't send you to a place that if they know that it might not be a good fit, for whatever reason. I said, but, we've been lucky, I'd say like, yeah, but there are times that unfortunately, like, there are things that I am definitely on my student side, like things that they tell us that happen. And I'm like, I'm sorry that you had that experience. That's unfair to you. That's unfair that this was the experience that you had, because that's not how it should be. So, and that I think being realistic that happens, and not being an educator that acts like that doesn't happen.
Right.
And I'm like, I mean, stories of CIs that take students, because then the student does all the work, and then the CI is, sitting in the back, and, I'm big on line of sight. So I'm big on, like, every state has different rules, but we, when I worked in DC, we had to have line of sight with our students. So like, if the student was in the room, I could be behind the curtain, but like, I couldn't be in a whole nother room, and so, when students are telling me, that their CI left the building, or, something, and maybe there's handoff, maybe they handed them off to somebody else, but I'm talking about situations where there's no handoff, I had a student tell me that a CI went on vacation and gave her the caseload while she was gone, and she was doing home health.
Wow.
And she called me, and I said, absolutely not. Yeah. Not do that. That's, this is, we're crossing some, this is a liability. This is, no, you need to handle this now. You need to call this person. You need to do this. And then I think the CI acted like, she didn't know she couldn't do that. Right. I'm like, yeah. So, sorry, not to go off on a tangent.
No, that's okay. I love the stories. The stories are most helpful. But anyway, I guess thank you for being here and answering those questions, and shout out to your students.
Yes, thank you. I'll tell them all. I appreciate that. I was like, y'all submit those questions. We're not like hypothesizing what students want to talk about.
Right.
That we're actually hopefully answering the questions that they have. So.
Thank you. All right, everyone. Thanks for listening, and until next time.
Bye.